Okay.
Because they're still pouring in, and I haven't hit the start button yet, so they can't hear us until I hit the start button.
Sorry.
It's all good.
Did I hit you?
No, but you're not allowed to touch stuff.
No, it's cricket.
Okay, let me
I
move.
thought for sure I hit your head.
No, you hit my hip. You want me to do it? You go over there.
White coat, yes.
How's that video?
Yeah, good.
Okay, enough.
Next, move this.
Go, which way?
Next person.
You can't. It's the metal. It's not connected to the metal, to the frame. You have to pull from the frame. Watch. Never mind. I thought they weren't connected. Yes, they are.
Okay, that's better. Sit there.
Sit. You don't have
You
much
can take
time.
out your mask.
Fully off?
Yeah. Halfway is really.
Put it in so I don't have to do it mid.
It's on mute.
It's not on mute. It's not on mute, Dr. S.
How are you?
Hey, good morning, Dr. Smotrich. How are you?
Good. Thank you
for
having me.
hit the start button for everybody.
Not a problem.
Okay. All right. Are you steady?
On? Yeah.
People do this office and get this one set.
Does
Okay.
is it better? And it's better with him.
Yeah. No. You stay where you're at.
Yeah, we're trying to see how you look.
Okay.
Yeah, look like we have a lots of audiences on because we live stream to YouTube, Facebook, Tencent, WeChat too. So we have like over 200 participants on that. So whoever's on it, they can do the translation, interpretation, just in case anybody have questions. I'm gonna hit the start button now. Whenever you guys are ready.
So do you want me to go to the other room and translate?
Yeah, if you go to the WeChat group, I think Liz shared a little mini program. So pretty much an app inside the WeChat app. So that's a platform where we host the webinar for our Chinese audiences. So if you go on there, you can enter as a participant. But the way it works is like nobody gets to talk. So pretty much you can type, you can chat on the screen. So yeah, so just in case anybody asks, because I know we have a lot on there.
Okay, so I would just type in Chinese for them.
I'm sorry?
Do I just type in Chinese for patient?
Yeah, you may do that. Yeah.
Okay.
So do you want me to grab your laptop with us? Okay.
All right. Okay. All right. Let's get the start right now. Hi, good morning, everyone. Thanks for joining us today for a webinar in collaboration with the La Jolla IVF down in San Diego, and this is Dr. Smotrich.
Good morning.
He's done a phenomenal job in the fields of infertility and reproductive science. Had patients over from over 97 countries, if I remember correctly, and he did the first gay surrogacy in the state of California. There's a tremendous amount of information he wants to share with us. So yeah, thanks for joining us, and we will start by introduce and explain the IVF portion, and we'll get to the surrogacy side later on. So without further ado, Dr. Smotrich, it's all yours.
So thank you very much. It's my pleasure to be here with you today. I'm Dr. David Smotrich. I've been in our community now for the past 25 years in La Jolla, California, a suburb of San Diego. I've been very fortunate to have done over 9,000 IVF procedures. I've done over 6,000 egg donor cycles, over 7,000 cycles of surrogacy. And as Stefan mentioned, I've done the very first male-male couple using an egg donor into a surrogate. That case was actually done in 1997. It was the first case in the world. It was a case that allowed us to change the laws here in the state of California to have 2 dads and then subsequently 2 moms on a birth certificate. Since then, I've done over 2,000 same-sex couples of IVF using surrogates, and very, very excited to be here with you and be able to tell you a little bit about our practice, talk about how IVF works, address egg donation, surrogacy, genetic screening of embryos, and talk about how things are right now with regards to the coronavirus and how we're preparing things to protect our patients and future babies from corona. So would you like me to start now with overall treatment? So IVF is not new. IVF started back in 1978 with Louise Brown, the original child that was born in IVF technologies. In her situation, her mom had been pregnant 4 times previously. In normal, natural pregnancies, a woman releases an egg, sperm and the egg meet in the fallopian tube, fertilize in the fallopian tube, and then the embryo comes along the fallopian tube and enters into the uterine cavity. In Louise Brown's situation, her mother had been pregnant 4 times, each time in the fallopian tube, to the point where the fallopian tubes were too damaged and had to be removed. In her situation, they surgically removed a single egg, put the egg in a petri dish, created an embryo, put the embryo into the uterus, and then a whole new area of medicine was born. Since her birth, over 7 million children born worldwide using the technologies of in vitro fertilization. In vitro fertilization, generally we use, believe it or not, the birth control pill to put both ovaries in sync together, and then we use injectable meds to stimulate both ovaries. On the ovaries of a woman, each woman has follicles within each ovary, and each follicle has the potential for a single egg. Most women are on these injections for about 10 to 12 days. During that time, we use injectable meds to stimulate the ovaries. We use vaginal ultrasound to watch the follicles grow and develop. And then under ultrasound guidance, under anesthesia, in a simple procedure, I stick a needle through the vagina into the ovary, and we use a suction irrigation system to get the eggs. In terms of initial evaluation and what we do with our consultation, either I do it via Skype or in office. We review the entire history of the woman and male, depending on what the situation is with the patient. We're reviewing age, past medical history, surgical history, if they've been pregnant before or not, have they done in vitro before or not, getting an idea of the number of eggs, number of embryos, and most importantly, the number of genetic embryos that are normal. In terms of the egg retrieval itself, I've done over 9,000 of these procedures, as I mentioned before. This is a simple procedure done under ultrasound guidance, under anesthesia. Unlike an anesthesia for example, pelvic pain where you do a laparoscopy, this is an anesthesia that's oxygen and IV sedation. In a procedure where I stick a needle along the ultrasound probe, we use a suction irrigation system to get the eggs out. Normally takes me about 15 minutes. For frame of reference, if we call that Monday for the day of egg retrieval, we know number of eggs and quality of eggs. The number of eggs and quality of eggs is distinctly dictated based on the patient's age, her DNA makeup, her genetic makeup, and her ovarian reserve, and these are things that we try and determine with regards to the basic workup. So we do vaginal ultrasound to count the number of follicles. We do ovarian reserve testing in the form of anti-Mullerian hormone, or AMH, FSH, or follicle stimulating hormone, LH, or luteinizing hormone, as well as estradiol. I individualize every single patient care and every single protocol based on a patient's history, whether she's never done IVF before, she's done IVF multiple times. The day of egg retrieval, the woman will be in the recovery room for about an hour. We immediately give her meds to help with the healing of the ovaries, and then I like to see the patient the next day. On the day of egg retrieval, as I mentioned, we know number of eggs, quality of eggs. That same day, we surgically place a single sperm in each egg under the microscope. And when I have the benefit of meeting with you in person, I will show you pictures of eggs, of sperm, of embryos. This procedure in the laboratory is called ICSI, or intracytoplasmic sperm injection. It has been the standard of care for approximately the last 18 to 20 years. The next day, Tuesday, we want to see our patient in the next day to make sure her body's healing well. The next day, we know how many fertilized eggs we have. Generally, we like to grow embryos to the 5th and the 6th day. The stage is called the blastocyst stage, and it's this stage that we're allowed to do a procedure called pre-implantation genetic testing for aneuploidy, or PGTA, where we take a handful of cells that were destined to become the placental cells from an area called the trophectoderm, and then these are carefully labeled and sent out to a laboratory, and within a handful of days, we learn how many are chromosomally normal versus not, and male versus female. In terms of the IVF recruitment of eggs, as well as the egg retrieval, the most common side effects that we hear about is bloating, clear vaginal discharge, breast engorgement, nipple sensitivity. These are all side effects related to the hormones that we give to the woman to try and encourage the follicles to grow and develop. And these are very, very common. Most patients are feeling quite well within a day or two of their egg retrieval and have about 3 or 4 days of bloating afterwards. After the genetic screening of the embryos, each single individualized embryo is frozen using a technology called vitrification. In our hands, in our lab, embryos that we freeze, we have a 98 or 99% survivability of those embryos, so they do very, very well. And then once we know what a patient has with regards to embryos that are frozen, whether we're preparing a surrogate for a transfer or preparing an intended mom for a transfer, we use a very carefully choreographed protocol designed to build up the uterine lining. We use injectable estrogens, we use vaginal ultrasound, blood hormonal levels to make sure that her body's responding appropriately. And then the embryo transfer is done in a simple procedure where we place a speculum to visualize the cervix. We cleanse the cervix with culture media. I take a catheter and I gently place an embryo through the cervix high up in the uterus. This is done under abdominal ultrasound guidance. I'm a big believer in bed rest after an embryo transfer into a surrogate or into an intended mom. If the embryo itself is going to implant, highest likelihood of implantation occurs in the first 1 to 3 days. Can't diagnose it that fast, but that's exactly when it happens. So I have our patients on bed rest. Now, it's not rigid in bed, but we want them to take it easy and focus on allowing for the embryo to implant. 2 weeks after embryo transfer, we do a blood test to see if she's pregnant or not. 4 weeks after, we do pregnancy ultrasound, see if it's one or more than one embryo implanted. In our hands, over the last 5 years, placing a single embryo that we know is genetically normal into a properly prepared uterus, and in my practice, most of the time that's into a surrogate. We've been running between 80 and 85% pregnancy rate with a 1% chance of twins. How do you get twins placing one? That's God. The embryo itself splits and becomes identical twins. Same scenario, and we are doing fewer and fewer double embryo transfers, but I do have patients in my population who want 2 embryos placed. Frequently, the male-male couples that I work with would like to place 1 embryo from each gentleman. Sometimes we have couples that would like to place 2 embryos to try and enhance their chances for twins. So the pregnancy rates in those patients placing 2 embryos reaches close to about 90% pregnancy rate with about a 60% chance of twins and about a 2 to 3% chance of triplets. So how do you get triplets placing 2? Again, the embryos split. become identical twins, and then the other embryo implants. In terms of our embryology lab, our lab is located in our actual suite. My laboratory director is Dr. Barry Baer, who's considered one of the top 5 embryologists in the world. He's also the laboratory director at Stanford Hospital. And Dr. Sherry just walked in, and I will have her come and say hello. Dr. Sherry has been with me for the past 17 years. We've done thousands, come and sit, Sherry, sorry, and thousands of cases together in the IVF arena. Dr. Sherry is originally from China. She is a medical doctor.
Hello.
You can speak in Chinese too, I
哎，
think.
大家好。
Chinese and English, I guess. And she's done thousands and thousands of procedures with me in my laboratory. She's an expert in creation of embryos using ICSI, as well as doing pre-implantation genetic screening, the freezing of embryos, the freezing of eggs, the thawing of eggs. And she frequently meets with me with our patients to review their care. You can, all right.
You'll finish it.
I'm going to finish it. All right, sorry. She is intimately involved in every single case that I'm involved in, and we also have other embryologists in the lab, but Sherry's the most experienced, besides Dr. Barry Baer, as I had mentioned. And so we are doing all the advanced therapies in our laboratory, egg freezing, creation of embryos, embryo biopsy, and embryo transfer. So that's the laboratory. Did you want to say anything specific, or you just want to introduce?
I can.
Vivian, did you want Dr. Sherry to say anything specific?
Dr. Smotrich, are you asking Vivian?
Yeah, do you want her to say
No.
anything specifically? Okay, all right, sorry. Anyhow, so Dr. Sherry is here for questions, if anybody has questions for her as we continue. All right, so questions and answers after. Okay, sorry. Sorry. Anyhow, everything looks good here, and so that's what's involved in terms of the creation of eggs, creation of embryos. There's what other areas? I know, Stefan, you want to hit the next slide, please? Okay, so surrogacy, let me talk about surrogacy in general. So I've been very fortunate to do over 7,000 surrogate cycles in my career. I started doing surrogacy very early in my career, about 23, 24 years ago, and I've been told that I've done more surrogacy than any other individual doctor in the world. The babies that you actually see in this picture is a very interesting, lovely couple who had failed multiple times previously to coming to our practice. And we put 2 embryos into a surrogate, 1 embryo into the intended mom, and all 3 of the embryos implanted, and they have 3 healthy babies there, and that's delivered right around Thanksgiving. So we were all very pleased to be able to see the outcome on that particular case. Surrogates in general are women who've had no problems getting pregnant. Before we will review a surrogate, we call for all her old records to look at how easily she got pregnant. Did she have any issues in pregnancy, issues with elevated blood pressure, diabetes, thyroid disease, kidney disease, issues with premature delivery, premature contractions? Did she have issues with postpartum hemorrhage, postpartum depression? We have them see an obstetrician to make sure that they are healthy enough to carry. And unlike many of our friends from different countries, many women in America after delivery frequently are quite heavy. So we need to make sure that the surrogate is not heavy during or preparation to try and get pregnant for somebody else. The surrogate herself will come to my office. I will evaluate her myself. We'll go through her health history. We'll focus on her environmental history. Make sure that she's a non-smoker, that she does not live with any smokers, that she does not work in an environment that there are smokers. And we want to make sure that indeed she's a good enough candidate to go forward. I take the time to look inside her uterus to make sure there's no scarring or polyps on the inside of her uterus. We do infectious disease testing on her. We do urine drug screening on her for drugs, alcohol, tobacco breakdown products. We look at her blood type and antibody status. We look at her thyroid as well. If she has a partner, we test the partner, and even though there's about a 3-month period that she has to have pelvic rest or no sex during a surrogate cycle, there are things that couples do that are completely asexual that potentially can cause infections. So, for example, I've been married for 30 years. There are times when I will drink more water than my wife, and I will take her glass and start drinking from her glass. And then if she drinks after I drink, the simple act of drinking from a glass that I have drank from, if I have active hepatitis, she could get hepatitis during that interaction. So that's why we test the surrogates partners. We look to the agency to make sure that psych has been done. We look to the agency that makes sure that legal has been done. And then after I get what I call the blessing from the agency, I use a very carefully choreographed protocol on the surrogate designed to block her ovaries so there's no way for her to release an egg, and therefore no way for her to get pregnant other than us placing your embryo into her. First set of meds is the birth control pill, puts both ovaries in sync together. Second set of meds I use is injectable Lupron, which is a hormone that hormonally shuts the ovaries down so that there's no way she can release an egg, and therefore no way for her to get pregnant other than us placing your embryo into her. We use injectable estrogen to build up the uterine lining. We use vaginal ultrasound to watch the lining grow and develop, and blood hormonal levels to make sure her body's responding appropriately. Approximately 5 days prior to the transfer, and in a very carefully timed situation with regards to the start of progesterone, because we like to do our blastocyst transfers between 120 and 124 hours of progesterone exposure. We use the progesterone to help ripen the uterus to allow for an embryo to implant. And then we do the embryo transfer that I had previously described. As I mentioned, I'm a big believer to bed rest. We do 3 days of bed rest for our surrogates, and then we follow them very carefully hormonally to make sure that their body is absorbing the hormones well. So they'll be on estrogen and progesterone throughout the preparation, as well as in the post-transfer pre-pregnancy blood test, as well as after we know that the surrogate is indeed pregnant. Once we know the surrogate is pregnant by blood test, then we start to do ultrasounds. And I follow the surrogate for the first 10 weeks of pregnancy. During that time, she has weekly visits with us for ultrasound as well as blood hormonal levels. And then we start to taper her off her meds and send her to the obstetrician. Now, I want to bring up something that is very important. And surrogates are very special women that are helping us help couples become a family. And so while many of them are very excited and are very encouraging in doing this process, and we are as well, we take great and deliberate evaluation, especially of their prior histories. And so there are things in the medical records that a patient may not remember or may not have been told to them that are severe. And so there are quite a few surrogates that women who want to be surrogates, but unfortunately we will not allow to be surrogates if it's medically not appropriate for them to get pregnant. And so while, thank God, this is rare, it is something that I take very seriously, because the last thing we want is to have a wonderful surrogate be ill during a pregnancy or have a severe outcome that can harm her family, as well as harm the outcome or the baby that she is carrying in the intended couples. So frequently people are surprised when I say, you know, I'm sorry, but we can't go forward with this surrogate. But there are times where surrogates will say, you know, I think I had a little bit of shortness of breath during the pregnancy, and she was told that she had asthma, and then you go back in and you start reading the medical records, and you find that no, it wasn't asthma, that she had a cardiovascular malformation, which would cause harm to her, harm to her pregnancy, and harm to the outcome. So again, fortunately, this is rare, but it is something that we take very seriously, And we are very deliberate about who we allow to come in for further screening versus not. Whenever there's a time where we're not 100% sure about whether it's appropriate for a surrogate to go forward or not, then we will refer them to a high-risk obstetrician who has extra training in high-risk pregnancies to try and figure out, is it safe for the surrogate to go forward? Another category of surrogates are surrogates that we've done very well with before, and surrogates who've done it maybe 3, 4, 5 times. Well, when you have a woman who's been pregnant, 5, 6, 7 times, she herself can be at risk for getting pregnant, and there are risks with things like rupture of the uterus and hemorrhage. And so again, we're very, very careful with regards to which surrogates we'll work with. And again, this is for their own protection, their own health, ultimately the health of the baby that they're carrying, and ultimately for the health of the couple that the baby that we're trying to bring into the world for. So I just wanted to bring out the fact that the pre-screening of the surrogate, even before she physically comes to my office, is a very important component. From the time I meet the surrogate to the time I can do an embryo transfer generally is about 10 to 12 weeks, dependent on where she is in her cycle, depending on how rapidly legal can be done. And sometimes we're receiving embryos from different countries to put the embryos into the surrogate. And so sometimes that delays the process a bit. Could I have the next slide, please? Thank you. So as you can imagine, the whole world has been affected and impacted by the coronavirus pandemic. And this is something that we have been taking very seriously, actually, from the initial start of diagnoses. In years prior, as many as 50% of the patients that I physically saw in my office were of Chinese descent from mainland China. And the current administration had closed the borders back in February, I believe February 2nd of 2020. So a large percentage of the patients that we routinely were physically seeing, we were not able to physically see. In order to get into our office in our building, we're in a large medical building on the campus of Scripps Memorial Hospital in La Jolla. Since February, they've been taking the temperature of every single individual who walks into our building. So that's every doctor, nurse, staff member, patient, delivery person for the past 10 months. Anybody with a temperature is not allowed in the building. Our internal office, we also are taking temperatures of everybody, and we're going through a history and type of environment to see where they've traveled and if they've had any symptoms at all. Every single patient who gives eggs, who's having an embryo transfer, and anybody who's leaving sperm will be having coronavirus testing that is recent within a handful of days of their procedure in our office. Okay. The coronavirus clearly has caused tremendous stress on all individuals in the world, and this stress, it clearly can negatively impact a woman's creation and ability to make eggs. Fortunately, on the initial studies coming out of China, on the east coast of our country, New York, Boston, as well as the European countries that were early on to have a lot of cases, it is clear that the coronavirus does not pass through the placenta into the baby. It does not found in the uterus, but it can negatively impact a woman's egg quality, probably related to stress, as well as it's been documented to be found in the sperm of gentlemen and has lowered sperm counts approximately 20 to 25%. Now, this virus is a relatively new novel virus, and while everybody has been reading about it, hearing about it, and living through it for the past 10 months, seemingly 24/7, it's very important still to do all of the basic common sense things, wearing masks, washing your hands, avoiding people with symptoms, avoiding large areas, fact, one of the studies showed that the 5 places that you have the highest risk for getting the coronavirus is eating indoors, traveling on an airplane, staying in a hotel, going to a place of worship, and the most common place is a bar where alcohol is being served. In terms of pregnancy during the pandemic, there have been, unfortunately, many women who've gotten coronavirus during pregnancy. Again, it is clear that it does not pass to the fetus, but a woman who is very ill during pregnancy can now have a high-risk pregnancy. Unfortunately, there have been women who were pregnant with coronavirus and died, and also the fetus that died. It causes a lot of unusual things. It causes a pneumonia. It can cause blood clots that go to the lungs, blood clots that go to the brain, causing stroke, causing epilepsy, and all sorts of terrible outcome kinds of things. So it's very important to protect your family and protect the patients as well. Earlier in the pandemic, the American Society for Reproductive Medicine asked all of us to postpone procedures. That was basically in March and April when we were starting to learn more about this. And so we postponed hundreds of procedures. And fortunately, now we're able to do them in a way that we feel is safe and effective. And again, we are testing everybody, and it's very important for everybody to be as diligent as possible. Frequent phone calls that I'm getting now is a patient whose husband works in an environment that a coworker was diagnosed with coronavirus. So many of these kinds of phone calls are causing us to delay cases, to be as prudent and as thoughtful as possible to prevent not only the patient from getting the virus, but prevent the patient from exposing those of us in the office with the virus, as well as preventing a fetus from getting any exposure during a pregnancy as well. We are not allowing guests in the room for embryo transfer. If you went back a year and we had, let's say, a surrogate who was trying to be pregnant for a couple, we would frequently have the intended mom, the intended dad, the surrogate's husband, and frequently a member from the surrogate agency in the room, all for the transfer. Right now, we're having just the surrogate in. We're doing a lot of virtual FaceTiming in order for the intended parents to be in the room at the time of transfer. And we are limiting the number of people that are coming for appointments. For intended parents, I'm seeing intended parents together on the initial consultation as well as the day of egg retrieval, or for an intended parent, we're having spouses in the room for embryo transfer. That's what we're doing to try and protect everybody in my practice and all of our patients in our community as well. There's been a lot of excitement with the release of the vaccine. It's very important to understand that the vaccines are brand new, that they were released via emergency FDA okay, if you will. They're not FDA recognized or FDA passed, but it's under a unique emergency window. The vaccines are going to be assessed, and those of us in the medical field are excited to be able to have the opportunity to have the vaccine. It has not been proven to be safe in women who are interested in getting pregnant. It has not been proven to be safe to give to pregnant women as well. So if you have a surrogate who wants to get the vaccine, or you have an intended mom who wants to get the vaccine or has been vaccinated, the prudent thing to do is to wait at least 3 months prior to exposing them to an embryo to try and get them pregnant. I am hopeful that with the vaccine and continued understanding and continued medications that we will have a better handle and be able to have more people be able to travel and enjoy our practice and enjoy other things that San Diego and the world has to offer, hopefully in 2021. But I think that certainly January, February are going to be very similar to what we've done. How do I get the next slide? Because I keep hitting it, it doesn't work. Sorry. Next slide, please.
Oh, he didn't.
Okay, sorry. Costs, I think, is your department, sir.
Hi, Dr. Smotrich. Thank you so much for, and we already have a lot of questions, a lot of inquiries on all different platforms. Facebook, YouTube, here on live webinar, and also on Tencent. Quite a few. But after we done all our parts, we're gonna hold a Q&A section. So pretty much the cost of a surrogacy. I know that's the most concerning to lots of patients who, for some reason, that needs gestational surrogacy. First of all, there are two different types, but gestational surrogacy meaning you're using your own eggs or donor egg instead of surrogate egg, and a traditional surrogacy is no longer, well, it's still practiced, but it just very
Very rarely.
rarely, yes. And there are more states that are more traditional. There are some states that are more traditional surrogacy friendly than California. But in California, the surrogacy law is probably the most it is the most friendly for a long time. A lot of states try to use the California surrogacy law as a blueprint to establish their own. For example, Nevada. So fortunately, we're in California, but we do have a surrogates from across the country. And the cost of surrogacy, going back to this topic, it ranges anywhere. Well, this is more for California patients. In California, considering the cost of living and also how competitive, for you to find a surrogate. That's why the costs are much higher in the state of California. In other states, the surrogate simply doesn't ask as much compensation as the ones in California. So it ranges anywhere between 100,000 to 130, and even and it goes up from there too. Depends on the insurance policy and other factors. So how the costs are distributed across the different components. Of course, there's the surrogate screening and management fees. So the agency part of the cost to spend on management, the pre-screening of a surrogate, to do criminal background check on the candidate to make sure she's not she's clear on state, county, and federal level, that doesn't have any offenses that will severely impact her journey, or in general like she has very good characters. That process makes sure of that. Also, we do at our agency, we do a soft pull on their credit to make sure she doesn't have outstanding financial debt, outstanding financial obligations, because that would hinder, that would impact her motivation. Because we don't want the financial incentive be her primary motive. Legal fee normally that covers the surrogacy contract before she starts her journey. Once she's medically cleared at the clinic, she will go through the the IP will have their attorney to draft up the surrogacy contract, and the surrogate would have an independent attorney to review, to go over the whole surrogacy contract. So that covers that's the first portion of the legal fee. And after she graduated, so pretty much the first 10 weeks at the IVF clinic, after she go back to her obstetrician, she will start in the state of California, the lawyer will start on a thing called a pre-birth court order, pretty much a legal paperwork to establish your parentage even before the baby is born. So that constitutes the legal fees here. And the surrogacy benefit package, so pretty much all the money that goes to the surrogate, her base compensation, different kind of allowances. For example, the miscellaneous allowance to cover her mileage, travel back and forth to the clinic, food allowance, the prenatal supplements, etc., and also maternity clothing. It's very reasonable, and she will need different set of clothing during her pregnancy, and housekeeping and stuff like that. So we do have a detailed breakdown if you should be interested in doing a surrogacy journey. And surrogacy insurance that fluctuate the most, I would say. If you happen to have a surrogate that that she can be enrolled during the, we call it open enrollment period here in the state. For the most state is November 1st all the way to December 15th. In California, it's a little, it's still, they have a less stringent rule. So normally they will extend it, for example, this year all the way to the end of February. But other state, not every state is that fortunate. So if you happen to get enrolled in one of those ACA Affordable Care Act plan, it's much cheaper for her to get to cover her maternity care. Otherwise, we might have to go through some specialty type of insurance. Normally, it's backed by the Lloyd's of London, and it can be very costly. We don't suggest parents to pay cash because nothing happens. Of course, you save tremendous amount of money compared to insurance that's backed by Lloyd's of London. But at the end, if anything should anything happen, you never know how big your medical bill will be. So we will go highly against it if you decide to pay cash. And also, during the pandemic, we know cost might be the biggest concern for some of the surrogates. So if you feel comfortable to manage the journey by yourself, we do offer independent options. So pretty much we get you a match with a pre-screened surrogates, that's ASRM compliant, and you have the option to manage the case by yourself, and we will provide all the assistance to you. That saves you a tremendous amount of money. I think in the state of California, you lower the cost to 70 to 80,000 instead of the typical 100 and up for the entire process. I think it's one of the audiences asked how you match with a surrogate. So once we get we will show you a pool of candidates. They will have their profiles, and all their medical records are already pre-screened by our on-site nurse. And by the way, when we send it out to clinic, normally it will say, it will have a list of her past medical history and problems. For example, her first pregnancy, she had gestational diabetes, and the second one she didn't have it, all healthy. And the third one, nothing. Normally, a majority of the clinic will give her a go because she only had for the first, for the second or third is gone. But we will put detailed notations on every single one of her pregnancy, to pretty much make. But that's part of the HIPAA, so the clinic will get the information. But we want to tell you that we make sure all her medical records are pre-screened, and we will filter out. Don't want to use the word, but bad apples, beforehand. Make an appointment. So make an appointment with a surrogate. Then you will review her profile, and a lot of stuff you can have a lot of that can directly impact your matches. For example, different religious belief or different life philosophy. We have all that listed on the application. If you don't think that will you will create a strong bond or chemistry, you will tell that from looking at their profile. But a majority of the factor you can kind of fill it out when you do the match interview. It's either in person if you live in the state of California, or you have a very close physical distance with a surrogate. If not, normally it's done by Zoom or other similar type of video conference call, Skype or etc. And medical clearance cycle. Medical clearance that takes about a week. So medical clearance that depends on when her next period will be, and normally depends on the clinic. Different clinics have different rules, but normally 6 to 11 days after her menses, she will be sent to the physician who's done the embryo for the intended parents. And Dr. Smotrich already explained what type of blood work and ultrasound that needs to be done during that process. And when she's clear, she goes to the legal process to do her legal contract. And after graduation, is the pre-birth court order. Some state does it post-birth, but we leave it to the professional legal team to handle that. And after 9 to 10 months of pregnancy, she will help you build a family with lifetime joy. And so pretty much that's what I mentioned. Independent journey options. If you so really cost is really important to you. But good news is that I think a lot of companies, especially Google and Facebook, started. They realized they're one of the biggest fertility advocates. So they actually have a program to reimburse a certain amount of surrogacy cost. So we've seen that trend in the past few years. There's some more fertility and surrogacy reimbursement program, insurance, etc. So yeah, but if you still need to handle the journeys yourself, that would be that's one of the options. It's a lot of work to to manage the case yourself, but that on the flip side, it does save you a lot of money tremendously. Okay, and we do offer different financing program. I think La Jolla provide the same thing with United Medical Credit. And what I would suggest is that if you have existing mortgage loan, that would be a better option, since you have lower interest. It got spread over a very long term, 15-30 years. So your payment obligation will be significantly lower. If you don't have that available, or home equity, similar low interest long-term loan, of course you can seek help from specialty financing program. We do partner with Prosper Health Lending, and they have a somewhat favorable loan terms, but still they're higher than a cash out refinance or a home equity line of credit. Yeah, that concludes my part to talk about surrogacy agency and what we look for in terms of getting a good surrogacy candidate and egg donors. So this is our social media, and before we do the Q&A session, I'd like to do if you're interested in booking an appointment with the doctors David Smotrich, the center of your screen this is the telephone number you may call right away to get an appointment to schedule the consultation with him. And also, if you hit the button book now, at least you to redirect you to the website, so you can fill out the information, and one of the representatives will reach out to you. And if you're interested in meeting with one of the surrogate, or simply to view one of the profiles, if you go to the center of your screen and go to learn more, it leads up to our profile page. And if you want to look at the detail page, we have a little screening process to make sure you have the right intent. After that, we'll give you the roles and permission for you to look at the detailed surrogate profiles. Yeah, so that concludes my part, and we do have lots of questions from 4 different platforms. So Dr. Smotrich, I guess the first one is somebody is from right here. It's from Rosa Perez. Dr. Smotrich, would a 3-day embryo has a good chance to get pregnant?
Okay, so very good question. So there are various different stages in the growth and development of an embryo. When I was training and graduated my training back in 1995 from George Washington and the NIH, we only had the capacity to grow embryos to the 2nd day. Shortly after, while I was in practice for a while, they started to be able to grow the embryo to the 3rd day. It is a rare embryo transfer that we're placing day 3 embryos in. Frequently, we place them in if there are only a few number of embryos, or if it's very challenging for the woman to make embryos. Placing the 3rd day embryo into the uterus does have success, but unfortunately, you don't know a lot about those embryos. So you don't know the genetic makeup of those embryos. You don't know if they'd be able to make it to the 5th day, which is called the blastocyst stage. Frequently, day 3 embryos are only between 6 and 8 cells, occasionally 10 to 12 cells. So the uterus itself was designed by our maker, if you will, to receive embryos in nature at the blastocyst stage. And so that is why we try and mimic that as best as possible in the laboratory stage. But we are still doing day 3 transfers, probably a handful every year, and we've been fortunate to have success in those patients as well.
Right. Josh was asking, what are the potential side effects of undergoing IVF?
So the side effects are for the medications on the woman who is undergoing the egg retrieval, which I had mentioned, bloating, clear vaginal discharge, breast engorgement, nipple sensitivity. For the most part, nausea. These are short-lived. There is no increased risk of breast, uterine, ovarian tumors or cancers. And there have been, as I mentioned, over 7 million children born worldwide using these technologies. And when you do very specific testing to focus on the age of the woman giving the eggs, the age of the woman delivering, there does not seem to be any increased risk on the fetus or the baby in terms of their overall health and well-being.
Okay. And there are 2 very similar questions, one from YouTube, one from right here, so I'm going to combine it. So one was asking, would the genetic testing somehow hurt the embryo? The other one was actually, it's one of, I think she might be one of your, I came to the United States and did did my last cycle, but it all failed. I'm on the older side, and what the doctor suggests was like not to have my embryo, PGS, PGD. I didn't really understand why, because of the language barrier. So, and this, the one on the live webinar was asking would it somehow hurt the embryo, and the other one was asking what was the reason. Because she's on the older side, doctor suggests she's her embryo not to go through PGS, PGD.
Okay, so we were one of the first ever to do genetic screening of embryos. In fact, we did our first genetic screening of embryo case more than 20 years ago. The technology at that time, we removed a single cell from an 8-cell day 3 embryo, and it used to take 2 days to get results. They used to do a FISH technology and were able to only look at about 4 different chromosomes. We used to look at 21, 13, 18, X and Y, which are the sex chromosomes. At that point, we were removing 1 or 2 cells from the 8-cell stage and theoretically and probably harming embryos by removing about 15 to 18% of the genetic material just to make a diagnosis. Now, and I didn't mention previously, we were the very first laboratory ever to do a full 23 chromosome panel. That was done in my lab. We have the first singleton and twin pregnancies using 23 chromosome technology. And currently we are growing embryos to the 5th and the 6th day and doing a biopsy of cells at the trophectoderm level. And these are cells that were destined to become placenta. In skilled hands, in hands that are doing routine genetic screening every single day, every single week, every single year, the chances of harming the embryo itself is less than 1% in this current environment. And again, at the blastocyst stage, the embryos have reached about 132 to 140 growth and development cell stage. Frequently, you'll have an older patient who has 1 or 2 eggs, and she may have 1 or 2 embryos. There are 2 big schools of thought with these patients. Some you say, okay, we really want to try and do genetics, and so you grow the embryo to the 5th or the 6th day. We routinely look at embryos day 0, which is the egg retrieval day, so it's not even an embryo yet. Day 1, the first day of fertilization. Day 3, day 5, and day 6. Unfortunately, for older patients, especially over 42, as many as 90% of their embryos are going to be genetically not normal. Things like Down syndrome and other chromosomal abnormalities. So if that patient only has 1 or 2 fertilized eggs, 1 or 2 embryos, we frequently encourage them to place those embryos into the surrogate or into themselves on the 3rd day and not do genetic screening, because many of those embryos will stop growing in the laboratory. Now, the other thought with that is if the embryo stops growing in the laboratory and you're going to a clinically recognized CAP accredited laboratory like ourselves, that means that that embryo most likely is genetically not normal. But you can't diagnose it as genetically not normal until it makes it to the 5th or the 6th day, and then you're able to do a biopsy. In all embryos, or in all cases, even when the eggs are coming from a young egg donor, there is an attrition rate. So you may have a donor that has, let's say, 20 follicles. And the day of her egg retrieval, she may get, let's say, 18 eggs. And of the 18 eggs, 15 are good quality. Let's say we're using sperm that is good quality sperm. From those 18 eggs that are 15 are good quality, we would anticipate between a 75 and 85% fertilization rate. So on the first day, from those 18 eggs, of which 15 were good quality, let's say we have 12 embryos. This is a very specific, clear-cut case. Now we grow those 12 embryos to the 5th and the 6th day. Again, these are 12 embryos from eggs from an egg donor. We would anticipate that you have perhaps 6 to 8 embryos that have made it to the blastocyst stage. And then after biopsy of those 6 to 8 embryos, we would anticipate that about 4 of those are genetically normal. So no matter what case, no matter the age of the egg giver, not every follicle has an egg. Not every egg is healthy enough to fertilize. Not every fertilized embryo will continue to grow and make it to the blastocyst stage. And not every fertilized embryo that has made it to the blastocyst stage will be genetically normal. And unfortunately, not every embryo that is genetically normal is going to be healthy enough to implant into a woman's uterus and become a healthy baby. So there's a tremendous attrition throughout. So when you're starting with a woman, let's say she's 42, and unfortunately she has only 3 eggs, this is a tremendous challenge for that particular couple to have a healthy baby. Now, in our practice, we've been very fortunate to take care of women from all over the world. I've had 2 women in my practice who gave eggs at age 46 that had embryos that were indeed genetically normal and had healthy babies. Only 2 out of over 9,000 cases and hundreds of cases of women over 45. So it's tremendously challenging for a woman and the egg giver. Now, the oldest woman I've ever gotten eggs from was 49. I had a 49-year-old give us about 15 eggs, had 10 embryos. She had 9 that made it to the blastocyst stage, and unfortunately, all 9 were genetically not normal. So when people are having upfront, open, and honest conversations with their patients, which is the way in which I feel is the most important way to give the best education and information to the patient, then there are some patients that try and push the envelope. It is very challenging and unfortunately unforgiving for women who are over 42. Now, I've had 42-year-olds give me as many as 30 eggs. I've had 24-year-olds give us no eggs, and just about everything in between. So every case has to be individualized. Every case has to have a conversation where you discuss openly and upfront what the anticipated outcome is. And that is the best way to educate the patient, and the best way for a patient or an intended couple to make decisions. Now, it's very difficult because these are things that are very emotionally draining, and every woman has had a dream of having a child, and very few of them had part of the dream coming to my office and trying to get pregnant. So it's very stressful for a lot of patients, and a lot of things are involved, but we have to be open and honest. Again, the oldest patients we've ever had using their own eggs is 46, having healthy babies, but that's not the norm. Both women in that situation gave more than 10 eggs. So the concern for a woman who's older and only has 1 or 2 embryos, frequently we also are encouraging them to freeze early and put the embryo in early and see if the embryo implants versus not.
Right. Yeah. So thanks, Dr. Smotrich, and she did do some follow-up question on YouTube. So yeah, thank you, Dr. Smotrich, for the detailed explanation. And my other question is like how since I had a failed cycle last time, and the chances for me to get normal genetically normal embryos are pretty low. Would you say keep trying or to use an anonymous egg donor?
So again, every case has to be individualized and every situation has to be thoroughly evaluated, and I involve Dr. Sherry in my laboratory for their input as well, okay? Let's say you have a 42-year-old patient who was a very good responder and had 15 eggs and 10 embryos that made it to the blastocyst stage and were able to biopsy 10, and unfortunately, none of the 10 were normal. Okay? In that particular patient, I would have a conversation about perhaps changing the medication protocol and doing another stimulation, because that's a woman who is a high responder, and even with a more delicate, less medication type protocol, should be able to give a good yield of eggs and have the potential of having not only normal embryos, but normal embryos that will implant to be healthy babies. And that has been our experience. If you take that same patient and she's also 40, 41, but she makes maybe 2 eggs, then it's very difficult to encourage her to have her re-stimulate and try and do it if she only is going to be making 1 or 2 eggs. Also, the thing that frequently happens in our practice, and this is true, I'm sure with Patriot Conceptions, is we have a lot of international patients, and frequently the international patients have already gone to reputable places in their own country and have failed 4 or 5 times in their own country, and now they want to come to the United States and try and do something differently. And so I take the past history of the patient, I review very carefully the past protocols that they've done. I review this with our laboratory for input to see if there are any things that we can do protocol-wise or laboratory-wise to enhance their chances of success. But the main difference between men and women with regards to fertility is men can make fully functional sperm until they die. Sperm counts do indeed go down after age 50, significantly down after age 70. But we've had patients with their partners in their 70s where we were able to get sperm, create embryos in the lab that were genetically normal, and have healthy babies. Women, on the other hand, are born with every single egg they're ever going to make. And as I mentioned, I've been in practice for 25 years. I've had patients who, for sometimes genetic reasons, who, for sometimes because of past cancers and chemotherapy, are not able to make eggs even in their early 20s. So they're the age of an egg donor, but make no eggs. And I've had women in their 40s who are able to make a large yield of eggs and have embryos that are genetically normal. But every woman ultimately stops making eggs. So at age 20, at birth, women will have the opportunity to have about 2 million follicles. Once they start having periods at age 13 or 14, they'll have about 200,000 follicles, and every month they have a certain allotment of follicles that have potential for eggs. If those follicles are not stimulated with our meds, if those follicles are not blocked by the birth control pill, a woman will release normally a single egg. If that egg is not fertilized, that egg and all of those follicles for that particular month are blocked and absorbed by the body, never to come again. So there are women who reach the menopause, which means they no longer make eggs, in their late 30s, early 40s. The typical time when people stop making eggs is about 42 to 43. Now, we've had extremes in both cases, but it's very important to individualize those situations. So again, if you have a patient who's 45 years old, who's done 5 cases in Hong Kong and is only making 1 egg every time, and failed every single time, that patient probably will do better using an egg donor. I'm going to have Dr. Sherry add some information or answer some questions. Here's Dr. Sherry.
I Regarding the laboratory, any question I can answer? Just anything related to lab or anything connecting to clinic that I can answer. I'm here.
Okay. Dr. Sherry, I think we have one over here. I think it's this PCOS, PCOS. Would you suggest, would you suggest that, it's one of the PCOS on Facebook, and he, she wonders if IVF is a, it's very generic, but she asking, if IVF is good for PCOS patients.
Actually, this is a typical Dr. Smotrich question. We take care of PCOS patients very often. Let Dr. Smotrich start with, then I will answer you.
All right, sorry. Again, every case is individualized. The problem with polycystic ovarian syndrome patients, they don't typically ovulate on their own. The first line of therapy is to give them medications to try and get them to ovulate. Frequently, that's very difficult, especially in the very sensitive polycystic ovarian syndrome patient. And then you stimulate them, and then you have to follow them very, very carefully, because there are some patients that look like they have a lot of follicles but give very few eggs, or poor quality eggs. And frequently, we've had the experience where you'll have as many as 30 follicles and sometimes only get a handful of eggs. So it's a very, very difficult challenge to have patients with polycystic ovarian syndrome. I would say that about 15 to 20% of the patients that I take care of do indeed have polycystic ovarian syndrome. I've had a lot of experience with stimulating these patients. If a patient comes to my office, I see them myself. I do my own ultrasounds, I do my own procedures, and I'm intimately involved in each individual's care, with the laboratory. I'll now hand over to Dr. Sherry, and she can talk about what she sees under the microscope with the eggs from patients with polycystic ovarian syndrome.
Dr. Smotrich is talking about the clinical side. The PCOS patients has a follicle developmental issues. They have egg maturation issues. So once Dr. Smotrich had the egg retrieval, the egg came to the lab. Usually, these kinds of patients, the egg is a little fragile. Their morphology doesn't have significant difference, but we do feel it when we do ICSI. So these PCOS patients, we do require high-tech experienced embryologists to take care of it, to monitor them closely. Once they fertilize the next day, we look at day 3, day 5, day 6, following even day 7, to see all the developmental potentials, try to help each individual embryos to reach the blastocyst stage, that we can do the biopsy for the genetic testing. So the PCOS patients needed extensive medical care and then laboratory care. So we do really well in these kinds of patients, particularly for the patients, if she is willing to using the surrogacy, that will dramatically change their life and change their family structures, get healthy babies home. So at this moment, the PCOS is genetically from the family, but for the embryos, at this moment of time, we don't have the probe, any genes coding that the PCOS. There is a lot of studies coding the PCOS patients, but they clinically haven't used in the PGTA analysis results yet. So I hope in the near future, we can know more, then we can do the PGTA to eliminating the embryos with tendency or with any genetic thing to pass over to the next generation. That will be the near future study. So at this moment, we do genetic testing to transfer normal embryos with chromosome numbers, or if you have clearly genetic disorders in the family. So PCOS patients is the very special group, and then it's very I cannot say difficult, but it's not easy to. You need a very experienced laboratory, very experienced doctor to take care of you to have the good outcome.
Dr. Sherry. Actually, they do have another lab-related question here on Facebook.
Can I just answer specific two things? Because
Uh-huh.
Sherry's answer made me think about two other things.
Mhm.
We routinely look at patients' single gene disorders
Mhm.
and see if they have any common carrier traits. So, for example, just yesterday we had a husband and wife couple who had come to us from a different fertility center, and they had missed the evaluation of single gene disorders. And both the husband and the wife were carriers for a disease called cystic fibrosis, which is quite common in the Anglo population. And if they had not been found to have that, they would have had a 1 in 4 chance of having an affected child. So we're able to do genetic screening of embryos not only for chromosomes and the sex of the embryo, but we frequently do it for single gene disorders as well. The other thing I want to mention is that we have a lot of experience with very severe male factors. And in fact, just recently we had a couple from international traveled from Mexico where the gentleman had Klinefelter. So he himself was genetically had an extra X chromosome. These gentlemen have very, very small sperm numbers and frequently have to have a urologist help to surgically remove the sperm. Not only were we able to get sperm from that gentleman, get fertilized eggs for the couple, but have genetically normal embryos that would prevent the next generation from having Klinefelters, what the father has been suffering from. So this is how our ability to intimately and carefully work on every case between the medical side, the clinical side, and the laboratory side adds the benefit to our patients. And then I'm going to hand back to Dr. Sherry.
Yeah, Dr. Sherry, this anonymous guest on on Facebook Live, and he's from the East Coast. He said, last year we heard the horrendous news, how clinic, kind of mixed up the storage. And so it turned out his baby is somebody else, genetically. So what how does La Jolla, what does La Jolla lab do to, ensure this kind of stuff doesn't happen?
Yes, those stories is nationwide, worldwide. Everybody knows about it. It's shocking news. But for La Jolla IVF, we take extensive care of the embryos that frozen in the tank, which is liquid nitrogen tank, minus almost 200 Celsius degrees. Every single gamete, every single embryos came into the lab. Last year we installed the most advanced technology called the RI witness system. Every single gamete in the lab, they have their barcode on their dishes. The sperm came into the window. We have the barcode with the under the cup, and then every single step, we have 2 embryologists ID together each other with the RI witness stuff. They beeping in the computer with the iPad, and then with the barcode on the every single dishes label. So if it's anything non-match, they beep you right away. This is not going to happen that you cross over from someone's sperm inseminating to the other partner's eggs. So once the embryo and then the sperm was frozen in the tank, we have 24/7 monitor system to make sure they are safe. Their temperature was monitored every 5 minutes and reported to Dr. Smotrich, me, and also another lab staff. Anything has temperature dropped to certain degrees that we have the safe zone out there, they beep us, call us cell phone right away. So basically, 3 or 4 people in the lab, in the office, like 24/7 on duty to monitor stuff. So those kinds of stories are really scary. If it happens to anybody or any clinic, it is a disaster. But it's preventable if you take good care of your clinic, your embryos, your sperm, and then extensively have the responsibility to the layer of the people. So we have all these kinds of things, not only in writing, in paper, the policies, we also really practice in a way we are supposed to, and we take care of even beyond that. So for this kind of stuff, we can, if any patients come to see Dr. Smotrich, we can give them a mini tour to open the door, let them see what we are doing, what the stuff we have. I have been with Dr. Smotrich in the past 17 years. The thing that really impressed me is Dr. Smotrich is really willing to take the new technology, cutting edge technology into the lab, into the clinic. If anything can helping you, even somehow, even helping you to improve the pregnancy rate, to get better results, to have the better care, he's willing to do it right away. It's not like a huge giant clinic. They have a lot of approvals, a lot of paperwork to go through, but we move really fast, really quick. So our patient benefits a lot because we're the first clinic to do the PGT next generation sequencing PGTA analysis to helping you get pregnant. So even at day 3 time, like 15, 20 years ago, he's the first one. So in this way, we're really waiting to do our best to provide the care that to helping minimize, to helping increase the successful rate, minimize or even none, like the story you're telling us that happened in here. So we are really take good care of your gametes, your embryos, your sperm. So in this particular case, I think it's not happen here.
Yeah, thank you, Dr. Sherry. Yeah. All right. Yeah, Dr. Smotrich, I guess we try to wrap up the webinar. I think a majority of the questions are addressed, and a lot of questions on WeChat, in Chinese, the Tencent Live, and the Vivian's, answering each and every one of them. So I guess to wrap up the webinar, the one last question. It's a couple from Malaysia. We do we do plan to come to the U.S. and La Jolla, after this webinar, but we want to know what will be a good supplements for both male and female fertility. What will be a good supplements to take, a few months, beforehand, to make sure we are like at our optimal fertility health, fertility health.
Okay, so again, supplements are very specific, again, to the age of the woman, her ovarian reserve, and so not every woman would every supplement work out well. For women with reduced ovarian reserve, for women who are over 38, I encourage using DHEA, CoQ10, fish oils, and a baby aspirin, all designed to lower the amount of toxins that they have in their body and to increase the blood flow to the ovaries. For gentlemen, we add it's called nitrous, which is an increase. What's in that? NO+. It's I'll have it for you shortly, but we also use zinc. We also use arginine, thank you. Arginine, which is a NO2+, which helps for the formation of sperm. Most importantly, I think it's important to eat healthy and avoid toxins. Avoid tobacco, avoid alcohol. If you're living in a polluted environment, try and avoid polluted foods, air, water. And these will be things that will enhance your chances. In terms of our international patients, frequently I will do a phone consult or a Skype or a Zoom or a WeChat with them to have our initial consultation, and that will give us a chance to be more intimate to their own unique situation, and then we'll put together a unique protocol. I am very hopeful that with the fact that the vaccine now is available in many, many countries worldwide, that patients will have the opportunity to travel again And again, I'm sure it's going to be with masks and with other common sense kinds of things, but we will very much welcome our patients to come to see us here in La Jolla. And I want to thank you very much for the opportunity to work with you and with Patriot Conceptions. And I look forward to, working more closely with as many patients as possible to ultimately have their dream of adding to their families. During this crazy holiday season, I wish you all safe and healthy holidays, a happy and healthy new year. And I'm hoping that early in 2021, we'll be able to welcome our international patients again with a tremendous ability to take good care of them. And I want to thank Dr. Sherry for her dedicated work for our patients over the last 17 years and her continued dedication to make sure that our embryos are prepared in the safest manner with the most advanced technologies to add to our pregnancy rates. Because even if you bump a pregnancy rate by 1 or 2%, that's significant because every baby is a blessing. And I really hope that we'll be able to have the opportunity to work together. Shay, thank you so much. Bye-bye.
Thank you, Dr. Smotrich. Thanks a lot. Yeah, happy holidays, y'all.